unlike a broken bone, the fracture in a cracked tooth will never heal. If there is a bone broken, so doctors can do repairment and they do heal, but the cracked tooth does not heal. Each of the cracks and fractures discussed in this review have all been referenced in dental literature as vertical fractures, particularly those that involves the tooth root, whether originating from the cornel or apical root portion of the tooth. Then this from here it is just they said if the tooth is the the crack is involving the tooth root, they just mention it as vertical fracture. The interchangeable use of these terms is not appropriate because it causes a significant confusion clinically. There are distinct delineation as fractured cusp and vertical root fractures imply a complete or incomplete break of the tooth. Craze lines and cracked tooth are only incomplete breaks in teeth, and split teeth are only complete breaks in teeth. Okay, so fractured cusp and vertical root fractures can be complete or can be incomplete break. Then craze lines and cracked tooth are generally incomplete break, and the split tooth is complete break in the teeth structure. Then note too that the terms crack, fracture, and fracture line tend to be incorrectly used in places of each other throughout literature. Then classic signs and classic confusion. Crack in teeth often manifest as the so-called cracked tooth syndrome. This syndrome is characterized by, so what would be the patient's complaint for if the patient has cracked tooth? Acute pain on mastication, which is that the patient would tell you that I have a pain when I bite on my teeth and when I release the bite. So, of grainy, tough foods and sharp, brief pain with cold. So, you all know that why there would be pain when while biting and while the release of biting is because of the hydrodynamic theory. It states that whenever like there are cells like the A delta fibers and the C delta fibers, so the A delta fibers generally respond to the acute pain and the C delta fibers respond to the chronic pain. Okay, so whenever the teeth are biting with each other, there is a fluid movement in the dentinal tubules that would cause irritation to the pulp and would lead to pain. So same as with the release of bite. So whenever there is a release of bite, this tooth goes away. Then there would be again the movement of the fluid towards up, and these fluid changes is triggering the pain factor. Okay. All right then. However, cracked teeth may present with a variety of symptoms ranging from slight to very severe spontaneous pain consistent with irreversible pulpitis, pulp necrosis, or apical periodontitis. Even an acute apical abscess with or without swelling or a draining sinus tract may be present if the pulp has undergone necrosis. In other words, once the fracture has expanded, sorry about that. All right. So, in other words, once the fracture has extended to and exposed the pulp, then severe pulpal or periapical pathosis um, will likely to present. So, it's just like caries. So, with the caries process also, it starts with the reversible, then it goes to irreversible, and then later it ended up with the periapical pathosis. Same with the crack, it would start from the reversible, then irreversible, then periapical pathosis. This explains the variation in sign and symptom and therefore should not be termed a syndrome. The obvious and the obscure steps for crack detection and confirmation. If you do not look for cracks and fractures in teeth, you will likely not find them. If you will not look for, you will not find them. This is very good line. If a crack is suspected, several steps should be taken to confirm the suspicion. So what you can do if you are suspecting that there is a crack that is leading to the pain? Sorry. Okay, so there are these steps. First of all, you need to take history from the patient. Then you need to do subjective examination. Then visual examination. You need to check clinically into his mouth. Tactile, you can do the tactile sensation or tactile examination. Periapical test, okay, that you can try to uh, do the periapical test with the back of mirror handle. Then bite test, which would be the tooth sleuth test. Vitality testing done by the cold test to find out what is the status of pulp. Then periodontal probing, if there is any infection that is spreading into periodontal ligament or into the gum, and it is very important to find out the vertical root fracture, this probing. Okay, then radiographic examination, we can take a small x-ray of the tooth, we are more concerned about, although it is very hard to find a crack in the x-rays, but we can still try to look for if there is any sign we can see in the pulp, or any periapical sign, or we can see any crack. Then restoration removal, we can, if there is any restoration, for example here, we can even try to remove this restoration and see if the crack is going downwards, like we can try to chase the cracks, but this is very controversial thing. Some people does say that you just chase the crack, and some people say that you should not be chasing the crack. Then you can also try with some putting some stain and then seeing it under the fluorescent light, or the transillumination test, and the wedging forces, which would be same like tooth sleuth test, that you can ask the patient to bite by putting the tooth sleuth on the different cusp to see if any wedging forces are, making the crack propagate, and even by doing the surgical assessment. Okay, then they have described about the classification. First of all, the Craze line. When examining teeth for cracks, keep in mind that most adult teeth have Craze line. In posterior teeth, Craze lines are usually evident crossing marginal ridges and extending along buccal and lingual surfaces. So, what would be the Craze line? We will see in figure 1. Okay, so you can see, can you see this line? So this is the Craze line. These are only in enamel. Long vertical Craze line commonly appear on the anterior teeth. So they can appear on the posterior and anterior. On anterior teeth, they are more common as compared to the posterior one. And on the anterior teeth, they do appear as longitudinal. Okay, and as they only affect the enamel, they cause no pain and are of no concern beyond the aesthetic. Then, what would be the diagnostic clues? Craze lines are frequently confused with crack, but can be differentiated by doing the transillumination test. If the tooth is cracked, the light will be blocked, allowing only a segment of the tooth structure to light up. If the tooth only has a Craze line, the entire tooth structure will light up. Okay, then the fractured cusp. The term fractured cusp is defined as a complete or incomplete fracture initiated from the crown of the tooth and extending subgingivally. Okay, so fractured cusp would be, it is starting, it could be complete fracture or incomplete fracture, and it is initiated from the crown and it is going subgingivally, like this part is broken. So fractured cusp means this, like one cusp of the tooth is fractured. So it can either be going subgingivally and starting from the occlusal part. Usually directed both mesiodistally and buccolingually. The fracture usually involves at least two aspects of the cusp by crossing the marginal ridge and also extending down a buccal or lingual groove. Okay, the fracture will extend to the cervical third of the crown or root. A restoration is typically present. Usually, one cusp is involved, and the fracture is not centered as viewed from the proximal. All right. So, what would be the treatment for this tooth? Depending upon the amount of remaining tooth structure. So here, I think good amount of tooth structure is left, but here, if there is a big restoration present, so the amount of tooth structure would be less, right? So you need to first evaluate the restorability of the tooth. And tooth is treated by removing the affected cusp and restoring with a direct or a cuspal reinforced restoration, which is full crown or only. Okay, you can either try to place a filling over this cusp and cover it with the full crown or with the only. Then that covers the crack margin. Dentine and enamel bonding with adhesive resin is, if placed with special technique, have been shown to reinforce a weakened tooth structure and provide cuspal protection. Root canal treatment or vital pulp therapy is only necessary in the event that the crack affects the chamber, because this is not going towards the middle. So we can if there is no pulpal symptom, we can just put a restoration over here and cover the tooth, make a crown for this tooth or put a onlay. Okay, that would be the treatment for this tooth, unless there is no sign from the pulp. But if there is any sign from the pulp, then we need to do the treatment accordingly. Then the cracked tooth. So cracked tooth could be like starting from here, and they generally goes from mesial to distal. Okay, a cracked tooth is defined as an incomplete fracture. So they are not, the fracture is not separated from each other. They are incomplete fracture, and they are initiated from the crown and extending subgingivally. They have started from here and they are going towards downward, usually directed, and they are directed mesiodistally. The fracture may extend through either or both of the marginal ridges, like only from one marginal ridges, and it is extending towards both the marginal ridges. The fracture, the fracture is located in the crown portion of the tooth only, or may extend from the crown to the proximal root. Like here, it is only present in the crown portion, but here it is extending towards the root. Cracked teeth are described as incomplete, which is the green stick fractures, which also describe their form. Occlusally, the crack is more centered and apical than a fractured cusp. So, as compared to these fractured cusp, they are more centered. It means that they are more they have more chances of involving the pulp, and they are apical than as compared to the fractured cusp, and therefore more likely to cause pulpal and periapical pathosis as it extends apically. Then what would be the diagnostic clues? If a crack can be detected, use wedging to test for movement of the segment by using the tooth sleuth method to differentiate a cracked tooth from a fractured cusp or split tooth. No movement with wedging forces implies a cracked tooth. A fractured cusp may break off under slight pressure with no. So here they have divided. Like if you will give the do the wedging test with the patient. So if there is no movement in the tooth structure, then it would be cracked tooth. If the fractured cusp most likely would break, because that is a weaker cusp, and the split tooth will show mobility with wedging forces, and the mobile segment extends well below the CEJ. Then what would be the treatment? The treatment would depend on the location and the extent of the crack, which can be difficult to determine. Performing, because sometimes they do require endomicroscope to study like where the crack is traveling. Performing root canal treatment must be dependent on the determination of, you need to find out first what is the status of pulp and periapical. A tooth with a minimal crack requires root canal treatment only if the diagnosis indicates a need for it. A tooth with an extensive crack of long duration is more likely to require root canal treatment, but only if the diagnostic indicate. Okay, so if the diagnosis is like there is a pulpal diagnosis of irreversible pulpitis or there is a periapical pathosis, then only we need to start the root canal treatment. Other than that, there is no requirement. Then, therefore, pulpal and periapical diagnosis determines the treatment plan, not the crack detection. If a crack is evident on the cavity floor or proximal external surface, then what would you do? If the crack is extending and it has extended over the floor, it has covered the roof and now it is extending towards the floor. Removal of the fracture line only in the area of the cavity floor, that would include the initiation of an ideal endodontic access opening, is helpful in determining the apical extent of the crack and whether the pulp is involved. Okay, so according to this picture, so there was this restoration. They have removed this restoration and they want to determine what is the location of the pulp. So here the ideal endodontic access opening is helpful in determining the apical extent. You can try to make endodontic access cavity to find out if what is the location. However, keep in mind that the fracture is small and invisible at its further end even after staining, and likely continues deeper into the dentine than can be visualized. Okay, so it is hard to find, but you can still try it by removing the restoration and trying to do the excess cavity. But before doing all these things, it is very important that you communicate with your patient and explain them that what would be the diagnosis and what would be the prognosis of this tooth after doing all this procedure, because this tooth has a very big crack in it, and even if we are removing this part of tooth structure, then the prognosis and the crack is going deeper into the pulp, then the prognosis would be very less, very poor if the crack is involving the floor of the pulp and the pulpal floor, right? So the patient communication is very, very important, otherwise you can get into trouble. Then proximal surface, removal of the fracture line on the proximal external surface portion of the tooth below the level of the CEJ is not usually indicated. More information on the extent of the crack may be obtained, but it also is likely to cause the tooth to become non-restorable. So if the fracture line is extending below the CEJ, then the tooth would be non-restorable. Why? Because we won't be able to put a crown on top of that, because crown is very, very important to give the life to this tooth which is already weak. So if the margins is going below the CEJ, then we cannot really put a crown. We can take specialist opinion if they can do certain crown by doing the crown lengthening or other procedure, but the prognosis would be poor. Removal of the proximal marginal ridges and the tooth structure associated with the fracture takes away sound tooth structure, thereby decreasing tooth strength and resistance to fracture. However, keep in mind that not removing the crack on the proximal surface may allow, but if in other scenario, if we just leave the crack there in the proximal surface, then it is a path for the bacteria to travel, and that could eventually lead to root canal treatment or extraction. So every time you just need to weigh the benefits and the harms of every treatment, and you need to involve your patient in the treatment decision, what they want to do. Then, what would be the prognosis of these cracked teeth? In cases of cracked teeth, the patient should be fully informed that the prognosis is questionable because we are not sure how much is the extent and where is the location. This is not yet based on research evidence but is based on the principle that it is better to inform and prepare patient for the potential for failure, especially since these fractures have a tendency to grow with time. They can grow with time, they can spread. The long term prognosis of a cracked tooth is better when no crack is visible or the crack does not extend to the chamber floor and the tooth is rendered pain free by bending or the placement of a temporary crown. What you need to do with these tooth is you need to put a band around them that would help in more survival, better survival. And you can even try to place a temporary crown on top of that. That would, that would hold these tooth structures together and would help the patient even with the pain as well. Patients should be advised, however, that cracks may continue to progress and separate. Although treatment will succeed in many cases, some cracked teeth may eventually evolve into split teeth, but some cracked teeth would evolve into the next stage, which is the split teeth, and would require the extraction. Then split teeth is like a tooth is splitted into two parts. So we cannot do anything, right? So we need to take the tooth out. Then placement of a cuspal reinforced restoration while providing optimum protection for the tooth. It does not guarantee success, but is certainly beneficial. We can still try the crown for these tooth to help with their long life, but we need to discuss with the patient, and it can help some patients, not all. Only recently have studies been published that outline chances for successful outcome for cracked teeth. So these are the studies that they have given here, that the in 2006 study evaluated a small number of root filled cracked teeth with the diagnosis of irreversible pulpitis and determined a 2-year survival rate is 85.5%. The study indicated that the only significant prognostic factor were teeth with multiple crack, where teeth with multiple crack, terminal teeth in the arch, and the pre-root filling pocketing. So these are the some of the studies that was done. The treatment was placement of a crown restoration without performing root canal treatment. 20% of these cases converted into irreversible pulpitis or necrosis within 6 months and require root canal treatment. Okay, so if there is any crack, some theory states just put a crown on top of that, and just that would stop the spread of the infection, and that would help the patient. But some theory states if we leave the crack as it is and just put a crown on top of that, the bacteria present in the crack can cause and can irritate the pulp, and and sometimes at the end of the day we ended up doing the root canal treatments after removing the crown. So the prognosis is more variable with cracks than with other types of longitudinal fracture. Determining the position and the extent may be helpful in determining when to recommend extraction or with the placement of fixed or removable bridge or an implant. Treatment of extensively cracked teeth. A cracked tooth that is not separable and extends deeply in the root or involves the furcation remains one of the most difficult situations. And a cuspal reinforced restoration, which is the crown or onlay to bind the cracked segments and protect the cusp, is indicated unless the tooth is to be extracted. Again, pulpal and periapical diagnosis determines the final treatment plan. Many factors such as periodontal probing, x-rays, then bending can affect prognosis, and each of these must be considered carefully before proceeding with the treatment. While the determination of the extent of crack is difficult in these situations, the author recommend informing the patient of the finding and prognosis and providing all treatment alternative. Still, you need to give them all treatment alternative, which is we can try to place a crown on top of the tooth or the onlay, or we can do the sometimes we may need to do the root canal treatment, and then we would put on the crown, or we can take the tooth out and discuss about the replacement options such as fixed or removable bridges or the implant. Then the other type is the split tooth, which is just like this one, that the tooth is splitted into the two parts. So it is a complete fracture, and it generally initiates from the crown level and it extends subgingivally. And it is also directed mesiodistally through both the marginal ridges and the proximal surfaces. This crown is located coronally and extends to the from the crown to the proximal root. A crack that is more centered on the occlusion will a crack which is present towards more center would there would be high chances that it would involve the pulp of the tooth. A split tooth is the evolution of a cracked tooth, means it is a next stage of the cracked tooth. The fracture is now complete and extends to a surface in all areas. The root surface involved in the middle or apical third, usually extending towards the lingual. So here, what would be the treatment that we can do is, we can never save this tooth. The best treatment that we can do is extraction. The smaller segment will be very mobile, then there is a good possibility that the small segment can be removed and the remainder of the tooth can be salvaged. So we can try that, but the best option for the split tooth would remain the extraction. So we can discuss all these things with the patient. Then the vertical root fracture. So these cracked tooth and the split tooth generally extends mesiodistally, but the vertical root fracture generally extends buccolingually, and it starts from the root portion. They were starting from the crown portion. A true vertical root fracture is defined as a complete, it can be complete fracture or it can be incomplete fracture, and it generally initiates from the root at any level, usually directed buccolingually. The fracture may involve one proximal surface or both buccal and lingual proximal surfaces. The fracture is located in the root portion of the tooth only and may extend coronally, like from here it is going towards up. A review of vertical root fracture has been recently published. A VRF may extend the length of the root or occur as a short crack at any level along the root. The crack may or may not extend to both buccal and lingual surfaces. Then, what would be the diagnostic clues? Patients with VRFs typically present. So these patient does have typical features. So the cracked tooth patient would come with the severe pain, with the biting and with the release of the bite, and if the pain would be severe, shooting pain and the sensitivity. And these patient, VRF patient, would present with the minimal sign and symptoms, so they generally go unnoticed. So this pain is generally the vague pain, and until periapical pathosis occur, then they are very difficult to diagnose because they mimic other condition. The recommended treatment is almost to exclusively extraction. So for the cracked tooth, we are still giving the patient some option that we can do, like the crown or the onlays or the root canal or other things. For the split tooth, the although the best is extraction, but we can still give the patient a option that we can remove the very mobile part and we can try to salvage the tooth. But for the vertical root fracture, the only best treatment that we have is the extraction. Okay, or removal of the cracked or the fractured root, but care must be taken to avoid incorrect diagnosis. However, because VRF may mimic periodontal diseases or failed root canal treatment, these cases often results in referral to a periodontist or endodontist for evaluation. So sometimes if your diagnosis is not clear, then what you need to do is referral to the specialists, which are in this case, they are periodontists and endodontists. Virtually all VRFs have a history of root canal treatment. So they are most commonly seen in patients who had root canal treated tooth and a post in them. So even in the root canal treatment tooth, so they are more commonly seen, and some show normal probing pattern. However, most will allow deep probing. So in VRF case, if you will try to do the probing around the and this tooth, so you will found like very deep pockets, okay, and it would be at several levels. Then, however, most will allow deep probing in narrow or rectangular pattern. There would be a deep pocketing in this area. And this J-shaped radiolucency is very characteristic of VRF. Okay. Then okay, so the probing in narrow or rectangular patterns typically of cracked tooth lesion. The newer methods of analysis are currently being studied, such as cone. So, what are the other ways that you can try to diagnose VRF? Is the cone beam computed tomography, which is the CBCT, in order to help identifying longitudinal fracture in a non-destructive fashion. Having a sinus tract and a narrow isolated periodontal pocket defect is in association with the tooth that had a root canal treatment with or without a post placement is a pathognomonic. So if you find that any tooth who has root canal treatment done, and along with that you can see sinus and narrow isolated pocket. Okay, and the tooth had root canal treatment and with or without a post. And if there is any J-shaped radiolucency in the X-ray, so these all are the very characteristic signs of vertical root fractures. Okay, then the treatment planning. The only predictable treatment is removal of the fractured root or extraction of the tooth. Sometimes, if the vertical root fracture are present in the molars, or if it is only present in one root, we can still try to do the hemicectomy or root amputations. Okay, and we can save the other part of the tooth, and but the best option would be the extraction or the removal of that part which has got vertical root fracture. Researchers are looking into new treatment, but no method of saving the fractured root have been proven practical or effective as yet. And what would be the prevention? Because the causes of VRFs are well known, because that would be the root canal treatment tooth with or without post. Prevention is not difficult. What would be the rules? Avoid excessive removal of, when you are trying to do the root canal treatment, try avoiding excessive removal of intraradicular dentine, because that helps in strengthening the teeth. So this is a like an age phenomenon. With age, our dentine level decreases. That's the reason our tooth becomes weaker. So try avoiding excessive removal and minimize internal wedging forces. Compaction and condensation of root canal filling material should be carefully controlled. Post weakened roots and should not be used unless they are necessary to retain a foundation. All right, so we are done with this article, and with this article, I really recommend all of you to reading Odell case number 11. You will get much clarity with this topic, and it is very important. All right, thank you so much, guys, for watching my video, and I hope that this is helpful for you. And if you find it helpful, can you please recommend me to your friends and share it with your friends or whoever is in need. All right, thank you so much.